All right. Hi, everybody. Thanks for taking the time this evening to join us. I am filling in for Dr. Fisher, who is originally going to be giving this lecture, but we're talking about first trimester bleeding. It's something that we really commonly see in clinic and in the ER for some of us also. And so I was just going to go through it. I am Dr. Trivedi, for those of you who haven't met me or we haven't crossed paths yet. Sorry. Okay. This is the vision statement here. And I don't have any disclosures. So for objectives for today, we're going to try to go through and identify common causes of first trimester bleeding, recognize especially red flags that could require urgent escalation to a physician, or if on the phone, how to escalate and what would require escalation, performing the appropriate initial triage and assessment to be able to evaluate for the severity or stability of a patient, and understanding a little bit of background for the key diagnostic tools that go into understanding first trimester bleeding. So that can be labs and ultrasound basics as well as talking a little bit about patient-centered communication and support, and that'll be sprinkled throughout. All right, so for the background, so first trimester bleeding is very common. The definition is any vaginal bleeding can be spotting to much more heavy bleeding that is noted after a positive pregnancy test and all the way up to 12 to 14 weeks, which we consider the end of the first trimester. And so different etiologies or causes of the first trimester bleeding can be implantation bleeding, miscarriage, ectopic pregnancy, subchorionic hematoma, molar pregnancy, and cervical lesions. We'll go into a lot of these in greater depth, but to briefly just review some of them that we're not going to exactly touch on, but implantation bleeding typically is the precursor to subchorionic hematoma or subchorionic hemorrhage, but it basically is spotting that occurs from the actual force of the pregnancy growing into the uterine tissue. It is completely normal, and then we can see if that is something that is going to worsen into a subchorionic hematoma or not. And then molar pregnancy is a little bit outside of the scope of this talk, but basically that is a very abnormal pregnancy, and it can sometimes present as heavy vaginal bleeding. And then cervical lesions, typically that can be as severe as like cervical cancer, especially in a patient who hasn't been getting routine care up until the pregnancy started, or precancerous lesions of the cervix, as well as cervical infections, STDs that can cause cervical inflammation. And so why does this matter? So the prevalence actually of first trimester bleeding is really high. Like I said, it's very common. So bleeding in early pregnancy accounts for a combined 2.7% of all ER visits among reproductive aged women, or approximately 900,000 ER visits annually. So that's obviously a lot. Typically, my counseling for patients when I first see them, especially if they are having bleeding, is that after a positive pregnancy test, you have about a 30% chance probably of having some kind of bleeding in that early pregnancy. And then from there, that drops down to about 15%. Once we see cardiac activity, and then after that, as far as like miscarriage rates, it kind of continues to drop up until the end of the first trimester. So guiding principles of care. So the things that we want to make sure that we are doing when someone presents to us, either on the phone or in clinic or in the ER, with having first trimester bleeding, is to assess and address what their that should say patient's goals are. And then in regards to the pregnancy, in regards to their symptoms, in regards to the care that they would like. And then it's important to make sure that we're able to recognize what is acutely dangerous, and then ensure that we're able to provide timely referral either to one of the OBGYNs or to the emergency room if that's more appropriate. Um, when it's appropriate, there are times when we can offer some types of symptom relief. And then also I think probably the most important thing is providing the anticipatory guidance and kind of the clear safety or return precautions when a patient calls in or is seen and has these concerns. So we're just going to go through sort of some of the steps when you see a patient. This is assuming that you're in the clinic and actually seeing a patient either as triage as a medical assistant, or if you are helping in the clinic in another capacity. But the initial assessment that is typically helpful that we would do, and this is also what physicians are doing or any providers are doing when we're seeing these patients with first trimester bleeding. But the initial assessment looks for key history elements. So we always want to find, make sure we know the age of the patient, as that can play a factor in the risk for miscarriage, what their gender identity is, so that we can make sure that they're comfortable in our clinic setting. Their obstetric history, so depending on their gravidity, how many times they've been pregnant, how many times they've had a delivery, what the delivery route was, whether it was vaginal or C-section, and then specifically if they have had a history of hemorrhage or even a history of bleeding in the first trimester or early pregnancy, and then also if they have a history of an ectopic pregnancy in the past. Gynecologic or infectious history, we want to know if they've had any history of pelvic inflammatory disease or tubo-ovarian abscess. Those kind of go together, or really any STDs in general. Some of those can increase your risk for an ectopic pregnancy, or they may put you at risk for having cervical irritation, inflammation, like we had talked about, that can also lead to bleeding. Surgical history, if they've had any prior abdominal or pelvic surgeries, again, some of these can cause scarring in the abdomen and can lead to increased risk for ectopic pregnancy as well. Chronic medical conditions that can increase someone's risk for bleeding in any state. So bleeding disorders, if they're on an kind of anticoagulation, any of those things can definitely increase one's risk for first trimester bleeding in pregnancy. Contraceptive history. So, are they under the impression that they have an IUD in place and they have this pregnancy, or have they had their tubes tied or a sterilization procedure? In which case, that would definitely, both of those things would definitely increase your risk for an ectopic pregnancy on the differential. And then getting to menstrual and pregnancy history, finding out exactly what the first day of their last menstrual period was, when did they actually have a positive pregnancy test. Based off of those two things, we can estimate out what somebody's due date might be. They may know what the conception date was, plus or minus a few days, and then if they've had any prior ultrasounds in this pregnancy. Specifically, the other things as far as like for bleeding and for pain that we always want to look at. So the history of what's going on. So, if they're having pain, where is that pain? Is it more upper abdomen, lower abdomen, pelvis? How severe is the pain? Would you say it's mild, moderate, severe? Also, how it's been changing over time. Has it responded to Tylenol? Because of course, we would recommend that ibuprofen should be avoided in pregnancy. So as far as the bleeding, are they confirmed and for sure that the bleeding is coming from the vagina and it's not from another source? If they have been having bleeding, how long have it been going on for? How many pads are they filling? Or what's the quantity of blood that they believe that they're losing? And then again, if they've been passing any clots or anything like that, to make sure that they can describe that to us. Sometimes this will be, patients will report that it's like, oh, I noticed some spotting or some redness when I wiped, or I noticed that in my underwear, or like I went to the bathroom and then I noticed like a large clot in the toilet. So it's really like a spectrum of ways that patients report that. Associated symptoms. So some of this is to make sure that we don't have anything else going on that could be the cause of the bleeding or pain. So anorexia, nausea, vomiting, those things can be associated with like appendicitis, constipation, diarrhea, other like GI issues that can cause pain in the abdomen and pelvis. If constipation with hemorrhoids can lead to rectal bleeding. So a lot of different things, dysuria. You could have a really bad urinary tract infection that also is leading to some hematuria or blood in the urine. And showing up as spotting on when you wipe. And then we want to know about a fever as well to make sure that there's no risk for infection in the uterus or to the cervix or any of these things that would compound or make the situation more complicated. And then it's very important to always establish for any patient who's pregnant is, what their pregnancy goals are. So is this a planned or unplanned pregnancy? Is it a desired pregnancy? Is it a not desired pregnancy? And if somebody is unsure about that, making sure that we're able to counsel them so they're able to confidently and comfortably make that decision of what their pregnancy goals are. Sorry. Um, for physical exam, the things that we are looking at, some of this also you can see, when you're triaging a patient in the clinic. So obviously we're checking their vital signs, their BMI, if it's appropriate, checking their temperature as well. On abdominal exam, when we are seeing patients, we are checking for tenderness, very gingerly seeing if they have rebound, which is where you push into the belly, and then when you let go, that letting go or rebound of the abdominal wall is what causes more pain. If they have guarding, where they're like protecting their belly or they don't want you to push on their stomach. If you really have no idea about how far along somebody is pregnancy wise, typically this is more in like the ER setting that we would do this, is that if you can feel the top of the uterus, you can generally use that as a rough gauge for how far along they are. But again, we're talking about the first trimester in this particular talk, and at that point, the uterus is only about to the level of the pelvic bones and so usually not above the pubic symphysis where you would be able to feel it. When we do a speculum exam, we're specifically looking for bleeding. We want to know how much blood there is. Is it dark? Is it bright? Is it coming? Can we tell, like, is it coming from the vagina? Is it coming from the cervix? Is it coming from within the cervix, or is it coming from the surface of the cervix? Do we see what's called an ectropion, which is basically a normal occurrence in pregnancy that makes the cervix, that's a response to some of the pregnancy hormones. And it causes the surface of the cervix to be a little bit more irritable and easier to bleed. Do you see any cervical polyps, or is there any signs or symptoms of any kind of cervical infection that would be caused by an STD? By manual exam, when we do that, we're specifically trying to look for uterine tenderness. We're a little bit more ginger when we check for adnexal tenderness over the tubes and ovaries, because of course you don't want to put too much pressure in the case that you have a high concern for an ectopic pregnancy. And then typically cervical exam from the standpoint of a digital cervical exam, that's typically not something that is needed in the first trimester when we're doing these evaluations. Very rarely, a rectal exam could be indicated if there's a concern for a GI source or hemorrhoids. So this probably gets to a little bit more specifics of red flags that could come up either on the telephone, like, or my chart probably more commonly. And then also specifically in the clinic. So telephone red flags can be severe pain that's not relieved by Tylenol, vaginal bleeding that's saturating through 2 or more pads per hour for 1 to 2 hours. So we always say that that's too much bleeding. Really, any time in OB/GYN, we say that's too much bleeding, that they need to go to the operating room, or sorry, the ER. And then if there's any concerns with the patient's reporting any lightheadedness, dizziness, of course, if she has fainted or lost consciousness, all of those are very big red flags that she needs to be evaluated in an urgent or emergent setting. For the clinic, if a patient comes in, there's any concerns on triage or on visual inspection of any kind of hemodynamic instability, they look very pale, they're hypotensive, they're like diaphoretic or like are like sweating mildly, have a high heart rate, tachycardia. All of those things would make us concerned that the person has either lost a lot of blood or is continuing to lose blood internally, potentially. If they have severe pain, if they're having very heavy or brisk bleeding, even on, that they're either reporting or that you are able to see. And then if they have a fever, there is a chance in cases of complicated miscarriages where there's tissue that stays back, that somebody could have a significant infection in the uterus and can make someone really sick from that as well. So, talking about some of the diagnostic tests that we use and kind of what is normal, what do we expect? So, beta HCG is a pregnancy hormone that comes really uniquely from pregnancy. And then, how does that fit in with pregnancy tests and ultrasound? So, these numbers are the HCG values that we look at when we order lab work or when somebody gets blood work. And so, from 1500 to 3500, we call that the discriminatory zone. That's the point where on transvaginal ultrasound, we would expect, if it was a normal pregnancy, to see something intrauterine within the uterus. And so what we're looking for, that can be anything, that can be just a gestational sac even, and you get that checkbox. It doesn't mean that we've confirmed necessarily that it's a normal intrauterine pregnancy or even that it's a normal uterine pregnancy, but we at least should be able to see something at that point. Low sensitivity pregnancy tests. So I don't really think that these are widely used, but I just provided this information. So those pick up won't turn positive until somebody's HCG is 1500 to 2000. And so if someone is using that kind of pregnancy test, then at that point, we, again, similarly, it would be reasonable to order a transvaginal ultrasound as we expect that we would see something on that imaging. So the more likely scenario is that a patient's using these high sensitivity pregnancy tests. Those are the ones that typically, say that you can test like up to 5 days before your missed period. And so that comes back positive as the threshold is significantly lower. It's at 25 to 35. And so you can imagine if someone has a positive pregnancy test and they start having bleeding, they call in or message in and are looking for some guidance, and we can try to provide that. But from a imaging standpoint, there's a very low likelihood for us to be able to even see anything. Um, you know, at that point, probably what we would recommend until we know that somebody is at a HCG level where we would see something on ultrasound, we would recommend have them come in and trend their HCGs so that we can see what the trend is. So we'll talk about that in 1 second. And then from a clinic standpoint, or when we're interacting with patients, we want to make sure that we are ensuring that that they understand what the appropriate timing of ultrasound is, when ultrasound will help and when it wouldn't really help, as well as hormone, when we should get these HCG labs, and making sure that we are able to get those labs drawn in a timely fashion so that we can interpret them. So trending HCGs, what that looks like typically is that we have more than one HCG value. One single value is usually not very diagnostic, and it's not really helpful because we don't really know if that HCG is on its way up, on its way down, if it's changing or it's staying the same. And so trending the HCG, we have expectations of what should happen, and those benchmarks are set over 48 hours. And so having somebody who comes in, they're seen in the ER the night before, and they come into clinic the next day, and somebody draws another HCG. Those two values, they can give you a general sense, but they're not going to be very helpful to interpret what is happening for the most part. And so typically we have these minimum ranges that we expect, and we can use that for a little bit also providing some anticipatory guidance to patients as far as what would be normal, when would we be more concerned about an abnormal pregnancy. And so early on, the hormone level is rising more quickly, whereas as you get to about 3000 or the upper level of that discriminatory zone, it starts to rise a little bit more slowly. And so in general, I'll say like the minimum increase that we'll accept or think that, it's worthwhile for us to continue trending or at least getting this ultrasound, follow-up ultrasound would be at least a 33 to 35% increase. And then, if we have a slower rise or a plateau over time of those HCG values, that makes us concerned that there's possibly an abnormal pregnancy. Again, not knowing whether it's intrauterine or an ectopic pregnancy. And then the only time that it is sometimes helpful to get those closer HCGs is after an early pregnancy loss or complete miscarriage, spontaneous abortion, lots of names for the same condition. But once all of the pregnancy tissue has expelled from the uterus, if you have an HCG before and an HCG after, you would find that there is a greater than 50% drop. And that 50% drop actually happens much more quickly than 3 to 7 days. It would be like over even in 24 hours, you can see that. So if you see these, if you are concerned that somebody has a complete miscarriage or has an early pregnancy loss, you will see that their HCG levels, that's something that we can use to confirm that it was indeed a uterine pregnancy that passed and not necessarily that we don't have to be concerned anymore for an ectopic pregnancy. So looking at ultrasound, this is just kind of the sequential findings over the gestational ages going from 5 to like 5 weeks onwards of what you would expect to see. And so in the first picture, picture A, ignore that it has an embryo there, but that's basically what you would see as a gestational sac. And this is like two different views. And so you see this gestational sac within the uterus. It's very easy. And when you're doing the ultrasound or looking at these images to tell confidently that it is indeed within the uterus. And then, so that would be as early as 5 weeks. And then just one thing to clarify, which maybe I should have mentioned earlier, but when we're talking about these gestational ages, we're using somebody's the first day of their period. And so if somebody tells you like, oh, this is the day that I conceived, like I only had sex on this day, or I had a, embryo transfer, something that makes it like very specific. And you date off of that, it'll be 2 weeks less than what we are going off of with an LMP. And that's really expecting somebody who has a 28-day cycle. So it's making a lot of generalizations when we do that dating by last menstrual period, but it should at least get you kind of in the range of what is going on. So 5 weeks, again, that would be 5 weeks from their period. So about a week after a missed period, you would see a gestational sac. And then about 2 weeks after a missed period, 2 weeks after a missed period, you would expect on ultrasound to see a gestational sac with a yolk sac. So a yolk sac is the very beginning of the placenta, and it shows up like this little bubble inside of the actual gestational sac. Once you've seen that and you know that there's a yolk sac inside of the uterus, then that confirms that it is an intrauterine pregnancy. And that can really be very helpful when you're trying to put into context if somebody has bleeding after that, because you can at least, for the most part, rule out that it isn't an ectopic pregnancy and that it is a pregnancy in the correct location at least. 7 weeks, or again, 3 weeks after that after that missed period, you would expect that you should also see a fetal pole or an early embryo, and that it should have cardiac activity. Dopplers, like we do in clinic for further gestations, they can be used as early as 10 weeks, but again, depending on the person's habitus or, how their uterus lies in their body, if they have fibroids, those are all things that can make it more difficult for us to get heart tones using a Doppler. And so that doesn't mean that it's, that it's a miscarriage or anything like that. It's just a very non-specific way of checking for the heart tones that early on. And so you really should then try to obtain an ultrasound with like a bedside ultrasound is good enough to look for cardiac activity at that point. This is a chart that I made just as like a kind of a comparative overview. I used to use something like this when I would go over this with medical students, just to sort of help to differentiate the different scenarios that you can see with and these are all in the context of an intrauterine pregnancy. So I'll just generally go through those, and then the caveat being that we now have a global term that we use, early pregnancy loss, that encompasses a lot of these diagnoses, but they are sort of have nuanced differences. So somebody with a viable intrauterine pregnancy, they may have mild spotting. It could be implantation bleeding. It could just be spotting from an ectropion. All of those are normal causes of first trimester bleeding. Generally, they're may be associated with a little bit of cramping or not. It should get better with like Tylenol. If you were to do even a speculum exam, like the cervix should look normal. Maybe you see some friability or irritation on the cervix or some other non-uterine causes of potentially bleeding. And then if you were to trend the HCG, you would expect the rise that we discussed on that previous slide. And then on ultrasound, at that you should see a gestational sac with at least a yolk sac that confirms again that it's an intrauterine pregnancy. And then it just says plus minus an embryo with cardiac activity depending on how far out the patient is. For an incomplete abortion, typically these are the patients who are really presenting with significant bleeding, moderate to heavy bleeding, that can also be associated with moderate to severe pain. But these are the patients that typically, we'll see in the ER, or if we were to see somebody in clinic for this, they're bleeding pretty heavily where something needs to be done to complete that abortion or that miscarriage so that they don't continue bleeding that heavily. But so we talked about the bleeding and pain, and then on cervical exam, typically because this pregnancy is on its way out of the uterus, typically the cervix will have some dilation or you'll see clot there, and it'll visually look dilated. HCG, if you had an HCG before, they started having this bleeding and heavy bleeding. If you were to check an HCG during that time, you would expect that there would be either an abnormal trend where it hadn't risen, it could have stayed the same, or it could have dropped, but it still will be elevated. It won't have dropped down to like any kind of much lower level that quickly, especially if there's still pregnancy tissue within the uterus. And then if you were to look on ultrasound, you would see that there's probably what we call products of conception, like anything gestational sac, yolk sac, embryo. And then you may see also just like retained tissue that's just kind of, unclear, but like tissue that has blood flow to it. You could see blood clot that's there within the uterus, but basically something that needs to pass out of the uterus before that bleeding and pain will decrease or stop. A missed abortion, so that kind of the way that I used to teach that is basically you missed when the pregnancy stopped developing. So that a lot of times this gets diagnosed when somebody has no symptoms at all and just happens to be on ultrasound, or indeed they come in, they have mild spotting, mild to moderate pain, depending on where on the spectrum of that, how long that pregnancy has been not continuing for. But typically the cervix is closed, and so the body has not started to pass any of that pregnancy tissue. The HCG, if we were to check it over 48 hours, say they were too early for us to have gotten an ultrasound, you would see that there's an abnormal trend. And then technically the definition for a missed abortion really is once you've already seen cardiac activity on ultrasound in an embryo, and then the next time you scan them, whether it's a routine scan or it's for a particular concern, that comes back with having cardiac activity. And so you missed when that pregnancy stopped progressing or developing. An inevitable abortion, so that's these patients, they typically are like pain predominant as far as their symptoms, but they probably still do have like mild to moderate bleeding. Their cervix would appear open. They may have tissue at the cervix that's like, starting to pass, or it may on ultrasound just look like a gestational sac that's very low down in the cervix. The embryo may or may not still have fetal cardiac activity. Typically, the embryo will have fetal cardiac activity, but it may not still be kind of the gestational sac may look abnormal, sorry. And then HCGs at that point likely would be normal because really all that's happened is that the cervix has sort of started to open and you're having pain or cramping, but the pregnancy is still there and still producing hormone and still has cardiac activity. And so it has not yet passed. It's probably inevitable that it will, given the amount of dilation. And then complete or spontaneous abortion is when somebody previously, you may see them after this has happened, or they might be messaging back and forth, but they basically start having bleeding. Once the bleeding is sort of crescendoed and the pain also along with that has sort of reached its max and the tissue has passed out of the uterus, then after that they have significant relief of symptoms, both bleeding and pain. And then the cervix at that point probably is going to be closed appearing because everything will have passed out and the pregnancy is considered to have resolved. And this is the situation where you would notice that if you were testing even close together, that there's going to be a 50% drop in about 24 hours. And then on ultrasound, if it is truly complete or that everything has passed, you would see like an empty, normal appearing uterus without any kind of gestational sac or embryo or anything. And then, like I said, all of these terms, complete, spontaneous, missed, incomplete, are all collectively called early pregnancy loss. So talking about early pregnancy loss, we have some ultrasound criteria. I'm going to go through this a little bit on the quicker side just for the sake of time, but we have these very strict criteria that allow us basically to know with good diagnostic, just basically with good predictability when a pregnancy would no longer be considered viable and it would be considered that it's an early pregnancy loss. And so I won't belabor any of those definitions, but this is something that we look at when we have patients who come in either, for a new pregnancy visit and we have an ultrasound like this, or if we are seeing somebody and they have bleeding and in the early pregnancy, what makes us think that it's probably is actually a loss. Subchorionic hematoma or hemorrhage, people call it different things, but it's the definition of that is that there's a collection of blood that forms between the chorion or the placenta and the uterus. So there's a cartoon image of that here that you can sort of see where the subchorionic bleed is. And then this is a picture of this with ultrasound, what it appears like. Subchorionic hematomas, they do slightly increase your risk for having an early pregnancy loss, mainly by, if you can imagine in this cartoon, if the subchorionic bleed is sort of lateral on the lateral margin of that placenta, but because it is between the placenta and the uterus, if that bleed were to increase, it can indeed have like a shearing effect on the placenta and cause the placenta to separate off of the uterus, which would lead to a miscarriage. So that's the sort of pathophysiology of how that happens. But then, you can imagine that this can potentially also lead you to an increased risk of placental abruption. That's basically the same thing. It's just further along in pregnancy. Preterm labor and birth because of this like shearing force that's happening. Pregnancies of unknown location. So again, we are using our beta HCGs and our ultrasound to allow us to know, should we be expecting to see a pregnancy in the uterus? And if we are and we don't, then where is the pregnancy? And so the definition of a pregnancy of unknown location is basically where you have a positive urine pregnancy test or a quantitative HCG in the blood that is positive for pregnancy, but transvaginal ultrasound does not yet show a pregnancy, either ectopic or intrauterine. Any pain or bleeding without a confirmation of intrauterine pregnancy at that point requires us trending these HCGs, the quantitative levels of those of a blood hormone level, and likely requires an urgent ultrasound if that HCG is at an appropriate level where we would expect to see anything. When we trend those HCGs, we would do that basically until we have a diagnosis. So one example of that is if somebody comes in, they have bleeding early in pregnancy, we get their HCG, it's at like 200. We would say that, on ultrasound, we're not really going to be able to see anything, but we'll check your level again in 48 hours, give them return precautions, of course, for like bleeding symptoms that would be too much, pain symptoms that would be too much. But imagining that they don't have any of that happen and they come in for their 48-hour hormone test, we would basically want to follow that or at least extrapolate it out if it rose appropriately to the time when we think that their HCG would be in that discriminatory zone where we expect to see something. And so, imagining roughly that it doubles every 48 hours, we can kind of calculate out if you're starting at 200, 48 hours later, it was 400. We can calculate out like maybe in 10 days or something, you'll be at a level where we would be able to see on transvaginal ultrasound that there is a pregnancy. Clinically stable, if somebody is clinically stable and they have an abnormal HCG trend, Typically, that's an abnormal, or we would say that that is an abnormal pregnancy, but unless we've seen that yolk sac within the gestational sac at some point in this pregnancy, we still do need to rule out an ectopic pregnancy. And so that requires closer surveillance and closer monitoring of those hormone levels. And we will trend those down. If they're dropping, we trend those down to basically undetectable. And so that's like a lot of follow-up and calling patients and making sure that they're coming in for that blood work. Any kind of clinical instability in a patient who has a pregnancy of unknown location should be referred to the emergency department, because the most severe thing that could be happening is that they could have a ruptured ectopic pregnancy, which can be it's a surgical emergency. And so patients should be counseled that determining the location may take days, and it might take multiple blood draws, or multiple ultrasounds. And so this is something that is, a lot of times frustrating for patients, because it does require so much follow-up to make sure that we're doing the safe thing and giving them the correct information. For an ectopic pregnancy, so an ectopic pregnancy is any pregnancy located outside of the endometrial cavity or outside of the uterine cavity. Very rarely you can have ectopic pregnancies in the peritoneal cavity, like in the abdominal wall, in the ovary. All of those are very rare. The most common place to have an ectopic pregnancy is in the fallopian tube. And then just something to note, that the fallopian tube is able to rupture even with very small ectopic pregnancies. It's not that like somebody is measuring 7 weeks, and so therefore, if they had an ectopic, surely it would be something that would be causing rupture. Like very early on, even ectopic pregnancies can rupture. And then also even at very low HCG levels, which is why we truly will watch them down to almost to undetectable before we say that it's safe to for them to stop having those lab values drawn. On this first top image, you can see that this is what we'll see on ultrasound. That's like a dead giveaway that this is happening. So you can see the uterus, you can see that stripe, which is the white line that's kind of going up and down. That's where an intrauterine pregnancy should have been if it was going to be there. But instead, what you see is this ectopic pregnancy. So the tube is very dilated next to the uterus. When you put on color flow, you see that there's actually color flow to what I assume is an embryo in that image, confirming that diagnosis. And then this is just an image of sort of something that we would see in the operating room if we took somebody. So you can see that there's blood all around in the belly. So it's starting either in this picture, probably starting to rupture. But you can see how dilated that fallopian tube gets with that pregnancy, even very early pregnancy. And it's not something that's ever going to be a viable pregnancy. Patients will ask, like, is it something that can be like moved, or is it possible that it'll move down the tube, things like that, but that's never going to happen. And we need to manage it very closely. A comment, because we're talking about trimester bleeding, so on some updated guidance, and I don't know actually if our clinical protocols have officially been updated yet, but the updated guidance from ACOG and the Society of Family Planning has said that RH testing and RhoGAM are no longer routinely recommended for vaginal bleeding in the first trimester, or for early pregnancy loss in the first trimester, ectopic pregnancy, any of those. This is something, especially if a patient knows that they're RH negative, has gotten RhoGAM in a previous pregnancy, they may have questions about why they're not getting RhoGAM. It has to be a conversation with shared decision making, explaining that risk is not there the same way that it is in a pregnancy that's continuing on and made it to the third trimester, or made it past the first trimester, really. And so with shared decision making, it's not that it's not allowed to give RhoGAM. You still definitely can give RhoGAM. It's just that it's not routinely recommended. So for patient counseling and education, so if an intrauterine pregnancy is confirmed and the patient has mild to moderate pain and light bleeding, those things are common. They're usually not dangerous. ED precautions to give patients when they call and say they're having first trimester bleeding would be if they have severe abdominal pain, if they're having that heavy bleeding, 2 pads per hour for 2 hours, and of course, any dizziness or fainting. early pregnancy loss, the diagnosis of, if someone is calling, like, I'm having this bleeding early on, like, how do I know that it's not a miscarriage or an early pregnancy loss? You can counsel patients that that diagnosis is made based off of ultrasound, serial ultrasound, or at least like a downtrending hormone level. And then also provide, whether it comes at comfort or not, but there's nothing that can be done to prevent a miscarriage if it's going to happen. Um, After a complete abortion or an early pregnancy loss, it's common to have light to moderate bleeding for about 2 weeks. Cycles can be slightly irregular after that. And then you could even ovulate before you get your next period. And so you could even have a pregnancy before your next period. There's no required waiting period before trying again. So when I was in training, we used to say 3 months. I think that was pretty arbitrary, and somebody called that out that it was pretty arbitrary. And so there's, generally what I'll tell my patients is to ideally wait for their period to come back, mostly so that we have a precise way of dating them, more precise way of dating their pregnancy. But there's no required waiting period to try again to get pregnant. And then if somebody has had 3 or more early pregnancy losses and they desire future pregnancy, then they should be evaluated for recurrent pregnancy loss. Just a summary of some of the stuff that we went over. Again, that first trimester pain and bleeding is common. Our role is to make sure that we're taking a careful history and exam, whether that's over my chart, on the telephone, in triage, recognize red flags that you might be the first person that you are hearing them on the phone or seeing them in a message or seeing that patient in the triage rooms, recognizing those red flags so that you can indeed appropriately escalate to whomever that would be, whether for medical assistance, whether that's a nurse, whether that's your provider, whether that's, telling the provider while also coordinating for the patient to go down to the ER. Coordinating HCGs and ultrasounds. We, as providers, we usually are doing that because we're watching them so closely, but I know it's definitely in some of the nursing protocols for first trimester bleeding to, order those labs and ultrasounds when appropriate. And then providing education about the commonality of this, that there's nothing that you can do to help this, about ROGAM, about what the safety concerns would be and when they would need to come back to the ER. And then always, like, if there's a doubt, we're always here to help or to be able to be escalated to us. That's all I have. I wanted to make sure we had some time for questions. I know that was a lot, but hopefully slightly helpful. You can also throw it in the chat if you'd like.
Hi, this is Yelena. I had a quick question from a non-clinical
Yeah.
standpoint.
Yeah.
What would you say, or what would be your recommendation for how non-clinical support staff can help to reassure these patients without leading to under triage or over, like making a patient overly anxious?
If you're seeing them, in the clinic.
In the clinic, like at the front desk or in the contact center. I know this is a pretty common like question or concern, obviously, at the beginning of like their pregnancy.
Yeah. I mean, I think if they haven't, it's really hard because we have a lot of patients, especially if they haven't established care for that pregnancy yet, and they, if they have bleeding, we've just gone through like the wide differential of things that it could be, and so stressing the fact that it is something that's common to happen, and then making sure that they're educated about the warning signs. I think that could be appropriate. At the same time, if we can also escalate to having a provider or a nurse talk to the patient, especially if they have an upcoming appointment.
Do you think it sounds like we have like clear protocols in place and I'm just curious to see if we deviate from this today or if you find that when these do reach you, if there's a common inconsistencies or miscommunications to patients or delays that we could have avoided. Um,
Oh yeah, I think um, probably typically people will get that HCG over 48 hours, but I think sometimes the ultrasound gets scheduled too early, where we wouldn't see something. Um, And even if it's like somebody's second ultrasound after having a first ultrasound that didn't confirm an intrauterine pregnancy, sometimes if that is done too soon, then we are just left in a situation where we can't counsel the patients appropriately because we just don't have enough information, or that, we've gotten this ultrasound too soon, so we can't confirm that it is indeed a viable pregnancy. So I think that's probably what I've seen the most, I would say.
Thank you.
But
Yeah, thanks.
hey, it's Dr. Christmas. Thanks, Dr.
Hi.
Trivedi, for giving this lecture. It is definitely probably hands down, one of the most common things that
Yeah.
the MAs and nurses are encountering. But I do think Yelena's question about when do we, because there is a protocol in place that says if somebody calls and they're having first trimester bleeding, that they can reflexively, the nurses order that
Mhm.
repeat or order the beta HCG as
Yeah.
well as an ultrasound.
Hmm.
And I think sometimes it's really hard for them to know based on what the patient is saying
Right.
what their gestational age is. And so
Right.
I would say, especially if they've already established care, if there's any real question, you can always reach out to the provider and just say, hey, this patient called and I have pended an order for the ultrasound and the
Hmm.
CBC. If though it's somebody that we do have some direction on their dates though, then or going at things still erring on the side of caution and going ahead and ordering the ultrasound and the beta, especially if it may be a little bit of a wait before that patient can be seen because
Hmm.
they're just going to be extremely anxious,
Anxious.
even though we know it might be too early, but for them,
Yeah.
they want that reassurance. Even if it isn't reassuring, they still feel like that ultrasound is important and that we did something for them versus saying, you know, this is normal, wait for your 2 week appointment in 2 weeks.
Hmm. Yeah, I think one of the things that's been hard is when it's a new patient to the system, especially with a new pregnancy, and you don't have any prior relationship with them, and you get this message about that they're having bleeding and that this has been ordered, and kind of being a stranger and providing that guidance. It's hard for everybody, for nurses, for providers, because we don't know the level of concern that they're coming into everything with.
Yeah, exactly right. Yeah, so I think if they're not established patients and they haven't had that first appointment, we've been talking about having reserved PA slots that are
Mhm.
more urgent slots to kind of fill those with those patients. And I think what we should start to do is look at that more and see if we can make that happen, since that's a common thing. Um, the other aspect too is that, the nursing escalation protocol is in place too. And if they have they fulfill any of the criteria where they need to be seen more emergently, either in urgent care or the
Mhm.
ER, then that's probably the most appropriate thing to do sometimes for patients that haven't been seen or established care before either.
Yeah.
More specifically, the urgent care and not necessarily
Mhm.
the ER, so they don't have to
Emergency room.
wait.
Yeah.
Yeah, because the urgent care facilities can get them in pretty quickly.
I do think that, I don't know if this has changed, but I think at least the Dearborn station, they don't have ultrasound, like any kind of pregnant uterine ultrasound there. But yeah, from at least from establishing care, getting somebody plugged in, getting those HCG values, doing an exam,
I
all
think
of
it's
that.
more that and just making sure
Yeah,
that they're stable, because I don't know that any of the urgent cares are going to do an ultrasound, but if
right.
they feel like it's critical need for that, or if there's pain or anything, then that would escalate them going to the emergency room.
Yeah.
Any other questions, guys? Quiet today. All right. Well, Dr. Trivedi, thank you.
Yeah, of course. Thanks so much, y'all.